Good morning, everyone. We are excited to announce that we have another ADO Metabolic Bone Group education series for you all to listen to today. I know previously we've kind of covered various topics about ADO, including the types and diagnosis and management. But today we are so excited to welcome Dr. Rakesh Mehta to speak about osteopetrosis and the blood. As always, we have a disclaimer here as part of these virtual videos. Information presented during these presentations are only for educational purposes, and they should not be in lieu of any care or advice you receive from your personal healthcare provider, and that we can't provide medical advice. But of course, if you have any questions, please feel free to reach out to us directly at our email address listed here, or you can also find us on our Facebook group, which these videos will also be available and you will have access to. Lastly, as a reminder, please do not post any personal information as part of listening to these videos. Like I mentioned, today's topic is going to cover osteopetrosis and the blood, and we have one of the leading hematologists here, Dr. Rakesh Mehta, to talk about this specific topic. He is a hematologist here at Indiana University School of Medicine. And as you know, I'm one of the research coordinators here in the Division of Endocrinology. I think it's on the next slide, but that's all right. We've covered it many a times before. He's worked with us for many years, and so we are so very excited to have him today and joining us today. So like I mentioned, we are covering the topic of osteopetrosis in the blood. Thank you so much, Dr. Mehta, for joining us today. We've discussed in previous videos, there are different types of osteopetrosis, recessive, dominant, and we know that these various types can impact bone formation in different ways. So I think what would be helpful for a lot of people, and even myself, is could you, since the blood is formed in the bone, for one, can you tell us the impact of osteopetrosis and how it has an impact on blood formation, as well as the function of blood itself?
Thank you, Amy. It's definitely a privilege to join again. I've sort of enjoyed being involved with the Metabolic Bone Group and always having a chance to talk about the blood is one of my exciting topics, since I guess I am a blood doctor. So let's just talk a little bit about the blood and then kind of give you an idea of its impact with osteopetrosis. So you will oftentimes hear of when you get blood drawn that you get a complete blood count. And this is really the main things that we want to look at. There are the white blood cells, which are your infection fighting cells. There's the hemoglobin, which are the red blood cells, which essentially just carry oxygen. And then the third cell is the platelet, which are these sticky little cells that help keep us from bleeding. So those are the main blood cells that we think about. And you have to recognize the white blood cells actually really cover many different types of cells. I like to think of the white blood cells similar to our armed forces. Just like in the armed forces, you have the Army, the Navy, the Marines. They all do something different, but their common goal is to protect the country.
Sure.
White blood cells, we have different types of white blood cells. They do different things, but their common goal is to really protect the body. So that's why there are these different types of white blood cells. Now you'll see there are these other things that we like to check out as well, but I wouldn't really concentrate too much on those. I think the main focus will be the white blood cells, these red blood cells, which is the hemoglobin, which we really concentrate on, and then the platelets. So when you think about blood cells, they all come from a stem cell. It's really quite remarkable that one cell has the capability to divide and to mature into all the different cells. And this is just a schematic that shows that you start with this hematopoietic stem cell that's able to divide, and then one of them kind of stays in the bone marrow, and then the other starts to divide and mature further. Now, the initial break is into two different groups. One are what we call our lymphoid cells, which are really turned into lymphocytes, and there's different types of lymphocytes. And the other is what we call the myeloid precursor cell, which has the ability to turn into the red blood cells or the erythrocyte, the platelets, and then these different types of white blood cells. But you can see there's a process where it starts with the stem cell, it divides, it makes this break into either a lymphoid cell or a myeloid cell, and then it further divides and further matures through many different steps until it gets to that functional cell that is then actually released into the blood.
So I have a quick question. So these stem cells, are these the ones that are also like represented in the previous slide? Like, that's like the base, right, of a CBC count, right? So those cells are what make up all of those other three main things that you're looking at in a CBC count. Is that correct?
Correct. So
Okay.
the hemoglobin is the erythrocyte or the red blood cell. Then the platelets are the platelets, and then the white blood cells really encompass all of
Okay.
these cells.
Great.
So, but they all start from the same stem cell.
Got it.
But as you can imagine, you need room as these cells start to expand to be able to sort of divide and mature into the normal cell.
Just a quick question. How long does it typically take? I guess quickly, in terms of how the process works.
It probably takes several days
Okay.
from where the body tells the stem cell, hey, we need more red blood cells. And there are different hormones that will do that.
Mhm.
To then start that process and for the cell to divide, and then slowly mature into this functional cell.
Okay, great.
So this is actually what a normal bone marrow looks like. Now, the sort of the kind of the darker red or pink area here is actual bone. You can't really see, but out here would be sort of the hard part of your bone. And then this inside is the bone marrow. So these blue cells are the bone marrow cells.
Okay.
You can see there's sort of these areas of white, and that's actually fat cells that are in the bone marrow.
It's quite a bit.
It is quite a bit. And so normally within our bone marrow, about half of the bone marrow contains sort of these blue cells, which are the cells dividing into the red blood cells and the white blood cells and the platelets. And the other half of it is the fat. And so the outside is what we call cortical bone. That's sort of the hard part of the bone that gives structure to the bone. And then the inside of it is this bone marrow.
Do the do the white or the fat, cells, are those typically heavy at all? Or not really, or can't really
Not
measure
really.
that? Yeah,
It's just sort of space that's in there.
gotcha. Okay.
And it's important because if the bone marrow needs to expand to make, say, more red blood cells. So
Mm-hmm.
somebody unfortunately is in a car accident and bleeds, and your red blood cell count goes down, temporarily you need to increase the number of red blood cells that you make. And so you can actually expand the bone, the actual blood cells to grow into that fat,
Huh.
because you can have some extra room because you need that extra room temporarily to make those red blood cells. And then once you've recovered after that accident, then it sort of goes back to the steady state here.
I guess I just never knew that there were, fat cells in my bone marrow, among other places. So that's quite interesting.
The fat cells actually do serve some other purposes as forming sort of the structure in some cases and providing
Sure.
the nutrients that is necessary for the blood cells. But the important point to see with this slide is that there's lots of room
Right.
that is needed for the body to actually make those blood cells.
Okay.
Now, on our next slide, this is unfortunately what happens to somebody who has severe osteopetrosis. So much of that bone, that outside bone, is actually even growing into the bone marrow. So now you see all this sort of pink here or here, and now there's not a lot of room for those stem cells to actually grow. So you can see a few of those blue cells here, and there's a few pockets here and here. It's a little bit harder to see on this lower power, but you'll see some of the kind of darker purple or blue here. But you can see there really isn't room now for these cells to grow. The bone marrow has been replaced by actually the outside or the cortical bone. And that has unfortunately taken up the room for our bone marrow. So now all of a sudden there's not enough room to make these important cells like the red blood cells and the white blood cells and the platelets.
Are these the same two images, just close up, or are they two separate ones?
They are. This is sort of from kind of farther
Okay,
away, and this is sort of magnified a little bit more so.
okay.
So now that you have, unfortunately, this sort of more cortical bone going into the bone marrow, you can't make enough of those blood cells. And that then impairs our ability to have enough of the blood cells. And these are the different things that can happen from it. So if you don't have enough red blood cells, we call that anemia.
Mm-hmm.
And if you can't deliver the oxygen that's necessary for the body to do its function, then people get fatigued, they get short of breath. Now, if you don't have enough of those red blood cells, you can temporarily fix that by giving a blood transfusion.
So with the blood transfusions, I know I've learned, and some patients with osteopetrosis really depend on those blood transfusions, right?
Correct.
Can you walk us through, the complexity of blood transfusions for someone who is dependent on these transfusions? I don't know if this is where this is important, but I know that this is something that's come up before, and it's an important question for people.
Absolutely. And we're going to get to that.
Okay,
Um, I'm just going to sort of outline a few of
sure.
the other things that happen in the bone marrow, unfortunately, and then we'll start talking about the sort of those, what happens when people actually need to get blood transfusions.
Perfect.
So as I mentioned, if you don't make enough red blood cells, it's the fatigue and the shortness of breath. If you don't make enough of those platelets, since those are the sticky cells that help keep us from bleeding, people will start having problems with bruising, nosebleeds, potentially blood in their urine or blood in their stool. Again, platelets are one of those things that you can transfuse. If you don't have enough white blood cells, then you start having the risk of infections, because all of a sudden you don't make those important white blood cells to try to fight off a bacterial infection or a viral infection. And so unfortunately, you can't do a transfusion of white blood cells. And so that's why the risk of infection becomes quite high in somebody who doesn't make enough of those white blood cells.
Right. Is that common to have a white blood cell transfusion? Just as general question.
It's just one of those things that you can't really do safely.
Right.
So we almost never do these white blood cell
Mm-hmm.
transfusions
Mm-hmm.
just because the white blood cells, when they go into a new person, will start actually attacking the person.
Right.
So, and then the other thing that happens when you don't have enough of that bone marrow space is the body tries to figure out another place to grow the bone marrow. Since you can't do it in the actual bone, it tries to figure out another place to do that. And so the place it resorts usually to is actually your spleen.
Hmm.
And so the spleen oftentimes gets bigger because sort of these bone marrow stem cells go to the spleen to try to make red blood cells and white blood cells and platelets. The problem is that the background or the other cells in the spleen are not like the bone marrow and can't really support making good red blood cells or good white blood cells or platelets. So you do get the spleen to get big, but it doesn't really help in the actual production of those cells. Problem is, if the spleen gets big, it's right next to your stomach.
Mm.
And all of a sudden, it's hard to eat because the spleen kind of squishes your stomach smaller. And so it doesn't take much food. Usually your stomach expands when you eat something, but now all of a sudden it can't expand because the spleen's in there sort of squishing it. So a lot of times people will start to lose weight because it's just hard to eat because of that impact on the stomach. So these are the things that happen, unfortunately, when the bone marrow no longer is able to make all the cells that it needs. So you asked about blood transfusion.
Yes, here it
And
is.
that's the perfect transition to this. So unfortunately, when the bone marrow is not able to support somebody, we have to do it artificially. And that's the way we do that is through blood transfusion.
Mm-hmm.
And so I thought I'd talk a little bit about just blood transfusion in general, and then talk a little bit about sort of the process that goes into that. Now, recognize that over 5 million people every year receive blood transfusions in the United States. And so that's probably a total of close to 15 million transfusions per year. Now, we rely on volunteers in the United States to donate their blood to support the blood supply. So people aren't paid for their red blood cells or their platelets. Now, there's a different thing called plasma, which people will be paid for, but that's something different. Really, the red blood cells and the platelets that we use to transfuse people, we solely rely on people being willing to actually donate their own blood and their own platelets. Now, this is all regulated by the United States Food and Drug Administration. So there are significant rules to try to help guide the blood centers around the country on how they collect the blood and then how they process the blood. Now, a lot of times people worry about the risk of infection. I'm old enough that I actually remember when HIV was first identified, in fact, even before it was identified. And sadly, a lot of that transmission of HIV was actually through the blood.
Mm-hmm.
Because of that, one of the responses of that back then, so this is late 70s, early 80s, people actually could get paid to donate blood.
Really?
But the FDA recognized that if you pay people for their blood, they may not be honest with some of the questions that are required to be answered.
Yeah.
They're important. And that's where it then became volunteer-based. Now you can see nowadays the risk of HIV being transmitted is probably about 1 in 2.3 million. There are a couple of other infections that we worry about, such as hepatitis risk, with hepatitis B being about 1 in 220,000 and hepatitis C being 1 in 1.8 million. To give you an idea about that, the odds of getting hit by lightning is about 1 in 100,000. So
Wow.
things like HIV and hepatitis C, we really worry mostly about. That risk is incredibly small. And quite honestly, even these numbers are probably getting smaller, every year as the testing for these things improves every year on trying to identify these viruses and sort of other things like bacteria and other things that are actually could potentially be transmitted. And so the real infectious risk of transfusion has gotten less and less over the years. So where does the blood come from? As I said, it's volunteers. There are some regulations around this. For the most part, the minimum age is 17, though unfortunately with the great need for blood, some states have actually dropped that down to 16. Though if you're 16, you do still need a parent to allow to okay you to donate that blood. People have to be over 110 pounds. They want you to be otherwise healthy. And we talk about that hemoglobin, which is sort of the blood test that looks at a normal number for men and women. And they require that number to be over 12.5 for a woman and over 13 for a man. The reason those numbers are a little bit different is because on average, a woman's hemoglobin runs a little bit lower than a man's.
Why is that? Do you know?
It's actually because of testosterone.
Okay.
So testosterone actually increases the number of red blood cells that somebody has. And so for that reason, a man on average has a little bit of a higher red blood cell count than a woman.
Okay.
Now, when somebody wants to donate blood, they do have to fill out a fairly significant questionnaire because they want to try to filter out somebody who might have unsafe blood.
Right.
And that's related to they'll ask about medications, about vaccinations, about blood exposure. So if somebody's gotten a lot of blood transfusions in the past, then the likelihood that their blood might react against somebody else's blood is a little bit higher. They ask about high-risk behaviors. Travel is important. If people remember back in the 80s and 90s, there was the concern about mad cow disease being transmitted in England.
Right.
And that's from this sort of very small pathogen called a prion. And because of that, if people lived in England during that time, they're actually excluded from being able to donate.
Is that still true?
It's still true that if you were in England living during that time, they still will exclude
Really?
from donating the blood.
This feels like a trivia question of some sort. Maybe not.
Actually, it could be.
It could, you never know, right?
Exactly. So, and then if people have infections, obviously they'll rule those people out as well.
Right.
So this is pretty much what they do is they collect what they call 1 unit, which is about a half a liter, 500 milliliters, which is probably probably a little bit less than a soda can, and or maybe a little bit more than a soda can. And what they do is they just sort of put the needle in, and then they sort of below this actually have the bag that collects the blood, and they kind of weigh it to know that they're getting the right amount, and then they're done. They'll also get a couple of test tubes because they have to do some extra testing on that blood.
Have you donated blood before?
I have.
Yeah.
So it's actually a pretty simple process.
Or have you been living in New England in the 70s and 80s?
Not New England, actually the country of England.
Oh, the country of England.
The
Okay, got
country of
it.
England. Sorry, I
Got
should
it.
have said that
Okay.
more clearly.
No, it's okay. I just wanted to clear that up, but glad you've been donating blood. It's important.
Absolutely.
Yeah.
So what they do is they take that bag and they'll spin it. And the one thing they collect are what we call the red blood cells, or the packed red blood cells. So these are just the red blood cells. And then they get sort of this other bag that has some of the platelets and some of the plasma in it. And they spin it again, and that's where they actually collect the platelets. And then there's sort of this other component of it that we call fresh frozen plasma.
Fresh.
But this is how we get the red blood cells and the platelets, which are the two main things. Now, there is a different method nowadays to sometimes actually collect platelets.
Mm-hmm.
So what they do is they put a needle in one arm and they put a needle in the other arm.
Is that
and they
safe?
take the blood out.
Yeah.
They put it through a machine that just isolates out the platelets. And then the rest of the blood actually goes back into the patient. So it really actually just pulls out their platelets. It's called an apheresis unit.
Is that a newer technique?
It is a newer technique, and you can actually get more platelets that way. Which is, and there's some other reasons, but that's the main way they now actually collect the platelets.
Mm-hmm.
So I mentioned that packed red blood cells. This contains about 250 milliliters of blood, and it's used sort of acutely to raise sort of the level of blood. And on average, it raises your hemoglobin by 1 point. So if your hemoglobin is 6 and you get 1 unit of red blood cell, it goes up to 7. Now, there's a little bit of variation depending on how big somebody is and some other factors that may play a role in that. But on average, we look to raise that hemoglobin level up by 1. That unit of, that unit of blood can be stored for about 40 days. And it's at a low temperature. So it's a little bit above 32 degrees Fahrenheit that it's stored. So it's in a refrigerator for that time. Now, special units of blood can actually be frozen. If people have sort of a unique blood in that they don't have sort of certain other things on their blood, they'll sometimes freeze that unit because it's such a rare commodity to get that specific bag of blood that they'll sort of freeze it and use it for people really around the country that sort of have sort of difficult to match blood. And we'll talk a little bit about the matching. Platelets, as I said, are used to treat the low platelet counts. As I said, they used to sort of get it from that bag of platelets for the big bag of blood that they collect. And that's called a random donor platelet. But what they would have to do is take some of the platelets from one person and combine it with platelets from at least 5 people to sort of get that one bag of platelets.
So it's not like a matching type of thing, like anyone can, you know what I mean? Like provide and donate platelets, but not have to potentially be a match. You know how there's, okay.
Yep. But when they do that new process, that apheresis,
yes,
they can actually get about 1 to 3 bags of platelets out of just one setting versus here where they actually have to pool it or add it to like 4 other people to actually get a bag.
Right.
So that's why those apheresis platelets are it's more efficient and you really get more platelets.
Totally.
The platelets, unlike the red blood cells that can be stored over a month, the platelets have to be used within a week.
Mm,
So it's a much shorter time
sure.
frame. Now, I know when people hear about getting blood transfusions, they hear about this ABO blood system. Are you type A or type O or type B? So I thought I'd talk a little bit about what that means. And this can be a little bit confusing, but really on the red blood cell, there's sugars on that red blood cell. And depending on whether you're O, A, or B, it sort of is defined by these sugars.
Do you know which blood type you are?
I'm type O.
Nice.
Which is like, as I'll show lately,
Yes,
the
yes,
majority of folks.
yes.
So really type O means that you don't have this sugar. Type A is a certain type of sugar, type B is a different type of sugar. So the thing is, if you have type A blood, you will recognize this sugar on the B as being something foreign, and you will make antibodies against that B. If you have B, you obviously have this in your own blood, so you won't make any antibodies against it, but you will make antibodies against A type blood. Because O doesn't have anything here, you don't make antibodies against it.
Ultimate donor, right? Or did I get
That's
it wrong?
correct. Yep. So if you're type O, somebody with A blood can get it, or somebody with B blood can get it, or some people will have some A and some B. So you're right, type O is the universal donor. If you have type AB blood, then you can get or get blood from anybody, because you can get it from A, you can get it from B, or you can get it from O. The problem is that if you're type O, you will make antibodies against A and against B, so you can only get blood from type O. So that's sort of how we differentiate sort of those A, B types.
Makes sense.
The thing is, what's not fully understand is that people make antibodies against either type A or type B very early in life, probably at the age of 2 or 3, even if they've never gotten a blood transfusion, they will make these antibodies. And so the problem is that if you give somebody who has A blood, type B blood, they will have severe reactions to that can potentially even lead to death. So it's very important that they know what type of blood somebody has and give them the right type of blood.
Sure.
So this is really the distribution amongst people in the United States, and then what type of blood they actually have. And so again, depending on your ethnicity, it varies a little bit, but you can see A or type O and type A are probably the most common blood types that there are, versus type AB is actually relatively uncommon.
And I am B plus, B positive.
All right.
So about, 25% of, which makes sense.
Yeah.
Yeah.
So, but that kind of gives you a little bit of an idea how variable this can actually be.
Yeah. Oh, totally. I really liked this chart. It shows, like you said, a lot of variability and just, a whole grand scheme of things. So
now, what people also sometimes hear is this RH, which is the plus or minus of blood. And this is actually a different set of sugars and things that are on the red blood cells. And it's either, even though it's a bunch of different of these antigens, and really they just are lettered. They weren't very original with these names.
yeah.
And you might go, well, where's A and B? Well, we've already used A and B with the big blood type.
So they went down the line. Yeah.
They went down the line. But this is something that either you have this complex of these or you don't. So if you have them, you're plus. If you don't have them, you're sort of minus. If you have them, then you won't make antibodies against them, so that you can get plus blood or minus blood.
Okay.
But if you don't have them, you will make antibodies for them, and so you have to get minus blood.
Okay.
Now, the thing about these is that you will only get the antibodies if you've been exposed to, like, if you're negative, you will only get this if you're exposed to positive blood.
Right.
And really, the only way you get exposed to positive blood is that if you've gotten a blood transfusion with positive blood, which we try to minimize, or pregnancy can do it as well. So if
Right.
mom is negative, but dad is positive, and so baby becomes
And
positive.
thinks that not trumps, but that, you know, becomes positive because dad was positive,
That's
correct?
correct. Then mom gets exposed during the pregnancy to it. We actually now give women who are negative something that is really what we call an anti-D antibody, and Winrow and different names. It's an injection that they'll get towards the end of the pregnancy a couple of times to prevent them from actually making these antibodies.
Okay.
Now, the thing is, there are all these other little flags or markers or antigens on the red blood cells. And everybody is much, much different with how they have those different antigens. And that's why every time they do a blood transfusion on somebody, they need to do this type and cross. Because what they're doing is they're screening for some of these other antigens that are so variable. And so they have lots of different names. And depending on the person, you may have some of these or you may not. And the more transfusions you get, the more likely you may start making antibodies against these other antigens. And so that's why
Increases risk and things. Yes.
yeah. And that's why even if you've had a blood transfusion, say a month before, the next time you get a blood transfusion, they're going to have to do that type and cross or that type and screen again, because they want to make sure that you haven't developed antibodies during that time. And that's sort of this type and screen where the first test is just looking at the ABO and your RH status, but then they actually look for antibodies against these other red cell antigens. And actually the final step that they do is they sit there and they figure they've got a blood product that they're going to use. They actually take the patient's sort of their plasma, which has the antibodies in it, and actually mix it with the red blood cells that they're about to infuse to see if there's actually a reaction. So that's really that final step to try to ensure that people don't have these reactions when they get somebody else's blood. And as I mentioned, that type and screen or type and cross only lasts for 72 hours.
Oh, wow. Yeah.
Now, while transfusions are wonderful, they do come with complications. And so I thought I'd talk a little bit about some of those complications. And the first of which is really the antibody production, which I've already alluded to. The more transfusions you get, the more likely that you might start making these antibodies against some of these antigens. And when that happens, it can sometimes become more and more difficult to find blood. Remember how I mentioned they'll sometimes freeze blood?
Yes.
It's for these patients who have developed so many antibodies that it's actually hard to find a match. And the great thing in the United States about the blood centers is they all communicate.
That's good. That's great. Yeah.
So if they find somebody who, has sort of a lot of these antibodies, they get on the phone and they say, hey, does anybody have blood that would make this, that would match this person? And somebody will sit there and say, oh, we do, we have a unit of this, and they can actually, overnight it to the hospital or to the blood center, which will transfer it to the hospital so that they can actually get the blood.
That's great.
Now, sometimes people can have what we call delayed antibody reactions. And so what happens is that if you actually have those antibodies, but you haven't been exposed to blood in several years, the body's not making the antibodies at that time. They have the capability to do it, but because they haven't seen blood in so long, when they do the cross match, you can't see any of those antibodies in the blood. The thing is, when they get exposed to that blood, that sort of reawakens that part of the immune system. And it takes about 5 to 10 days, but then they'll start making antibodies, which will start destroying those blood cells that have been transfused. And so that's sort of a delayed reaction. So somebody might do good after a transfusion, but then 7 days later, all of a sudden they'll start breaking down those red blood cells. So that is one of the things that can happen. With platelets, unfortunately, there's no way to cross-match the platelets very well. And so it's much more common that people will start developing antibodies against platelets. Now, they do have tried to develop ways to do the cross-matching of platelets, kind of like they do with the red blood cells, but it's not nearly as effective. And so, unfortunately, it's very common for people who've gotten a lot of platelet transfusions to, over time, sort of not react or not respond very well to the platelet transfusions. There are times that the blood bank will actually try to look at somebody's sort of immune markers and try to match it with somebody else who has sort of similar immune markers to see if that helps. And that's something called an HLA matched platelet. So that's something that can occasionally be beneficial, but there's sort of extra testing that has to go into that regard.
Sure.
Now, there are other reactions that people can get. Now, we call these minor transfusion reactions. Now, if you were the patient who all of a sudden got hives or back pain, it wouldn't be minor to you. But that's just the term that we use, because while these things can be very uncomfortable and not any fun, they're not life-threatening. So that's why it falls under the minor reaction.
Sounds like stuff you hear from, any medication that you take, fever, pain, but yeah,
things.
totally, yeah.
Absolutely. If somebody starts getting one of these types of reactions during the transfusion, they have to stop the transfusion immediately.
Yes.
And unfortunately, usually you can't go on with that, that transfusion. They may have to find another one. Right. But just because you get one of these sort of reactions, fevers, hives, back pain, something like that with one transfusion, it doesn't mean it'll happen with future ones.
Right.
It might, but usually it's sort of something in that particular unit of blood. And it's actually not the red blood cells that you're reacting to. It turns out that there are proteins that sort of get sort of in that unit of blood, and your body's actually reacting to somebody else's proteins.
Oh, interesting.
That's where that reaction actually comes from. Now, these are what we call some major transfusion reactions. And again, these have some sort of big terms to it, but these are potentially life-threatening. One of which is where it's this sort of odd reaction.
Sorry, I just saw
the interesting names to this.
Well, it's okay. It's all public health, medical terminology. Typically has lots of acronyms, so I just was looking at them. So, yeah.
We like to sort of assign very big words terminology to them, but then we don't want to actually use all the words. So then we come up with the acronym. So one of which is this thing called transfusion-related lung injury, or TRALI, where you sort of get a reaction to the lungs. And these can be severe enough that people actually temporarily have to go on a breathing machine or on the ventilator. Another one is, as you alluded to, TACO, which is, I don't know how people come up with these.
I'm not sure either.
But this is oftentimes that your body just gets too much fluid and it backs up in the lungs. And then there's this very, very rare thing where the blood will actually have some white blood cells in it, even though it's mostly the red blood cells. There are just a few of the white blood cells in there, and they actually start attacking the person that the blood was transfused into. So this is actually something that's common in patients who undergo a bone marrow transplant. It's pretty uncommon in the United States. It's most common if you get blood from somebody you're related to.
Oh, interesting. Okay.
Because usually what happens is those white blood cells that come into the body's like, these are not our white blood cells. They attack and get rid of them. So that's why those white blood cells never have a chance to do anything. However, if the blood looks fairly similar to you, then your body might be, oh, these look like
Great.
white blood cells
Yeah.
and let
Yeah.
them live, but those cells start saying, this is not
This is
sort
not
of my
quite.
regular body,
Something's wrong.
start to
Right.
attack it.
Right.
And probably the last thing that we do worry about when people start getting lots of blood is they start accumulating iron.
Hmm.
Every time you get red blood cells, you not only get the red blood cells, but you get the iron in those red blood cells. The problem is that our bodies don't have a good way to get rid of the iron. And so it just keeps storing the iron.
How is it typically like excreted or gotten rid of?
There's no way for our body to excrete it.
I see.
We lose blood either by, or we lose iron either by bleeding,
Okay.
which is why women during their childbearing
Mm-hmm.
age, when they have their menstrual cycle, as
Mm-hmm.
they lose blood every month, they lose the iron. And so they're prone to becoming iron deficient.
Sure.
Probably within the cells that line our intestines, there's a
Mm-hmm.
little bit of iron in there, and we might sort of lose a little bit of iron from that every day. But there's no other way to get rid of iron.
Hmm.
And so the thing is, iron has to be stored carefully in the body. So there are cells in the bone marrow that can safely kind of hold the iron. And there's some cells in your liver which can safely sort of hold the iron. But if your iron stores get more and more full, you sort of take up all this space in the bone marrow cells and the liver cells. And now the body has this iron and it doesn't know what to do with it. So it starts putting it in places that can't really safely store it. And so those are places like some of the normal liver cells that aren't able to store that iron, or the heart. And when it does that, over time, it'll start to injure the normal liver cells or the normal heart cells, and can actually lead to the liver actually failing or the heart failing over time. So it's one of the challenges, unfortunately, as people get more and more red blood cell transfusions.
Right.
Now, what can't transfusion therapy help with? As I've alluded to, the one thing it really can't do is help the white blood cells.
Right.
So it's a challenge. Really, antibiotics and trying to support somebody through these infections are the way to sort of help with that. The other thing it can't really do is help somebody with an enlarged spleen. That's, again, because it's those bone marrow stem cells sort of trying to do something in there, the transfusion don't necessarily make any difference.
Mm-hmm. Mm-hmm.
So. Now, over time, unfortunately, people can become somewhat what we call refractory to these transfusions, where they don't seem to help anymore.
Right.
One of those, as I already mentioned, is if your body starts making those antibodies. Now, with the red blood cell, most of the time we can find them, but there are some people who unfortunately develop so many antibodies, it's hard to find a unit of red blood cells. For the platelets, again, it's a little bit different. You make those antibodies against the platelet, and it gets harder and harder to find the right sort of bag of platelets to help that.
Right.
The other thing that can happen over time, unfortunately, is as your spleen gets bigger, when you actually transfuse the platelets or the red blood cells, the spleen sort of traps them all. And so because they're not able to get out of the spleen, unfortunately, it doesn't do a very good job of actually raising the number of red blood cells or platelets that are actually floating around in the blood. So that's another thing that can unfortunately happen over time as the spleen's getting bigger and bigger.
Does it cause for it to be removed entirely, or what do you typically do?
There are times that we have to do that, or if we take out the spleen, and you can live without a spleen. There are sort of vaccines and things that you need because there are infectious risks if you don't have the spleen.
Right.
The challenge, though, is if you take the spleen out, the place where those stem cells start to go is actually your liver.
Oh.
So the spleen is its first place that it wants to go to. But the second place, if they don't have a spleen, is actually your liver. And that causes the liver then to get big, and then can actually cause the liver to fail as well. So it's unfortunately a tricky situation when this starts to happen, unfortunately. So, all right. I think that was my last slide.
Is that it?
Yep.
I do apologize. I had not added you know, a slide that says, ways to contact us, but hopefully you all know, like I mentioned before, our Facebook is a great way to get in contact with us at any time. We're available by message, as well as our email address, endobone@iupy.edu if you have any specific questions. We're really, like I said, excited to really present topics on osteopetrosis and the various, content related to it. But we also do hope to kind of expand that to other rare diseases in the near future. So please be on the lookout for that. And I hope you've enjoyed this video. And thanks so much, Dr. Mehta, for taking the time to do this.
It's
So
been a pleasure. Thank
yes.
you.